Hi, I'm Dr. Ben Chan. This is a segment on temporal fillers from a trainer's point of view. And there is information in this clip that is not shown or discussed anywhere else, and I feel that I need to share it with those who are learning to learn about temporal fillers. What should you know about temporal fillers? There are three different planes for filler depositions. Some practitioners prefer one plane over the other. Personally, I inject into all three different planes. It is because of the aesthetic outcome I'm looking for. The injection plane depends on the condition of the patient that's presented to me at the time. It is a balance of risk versus results. The three planes are the superficial fat plane, the subdeep fascial plane, and the supraperiosteal plane. To understand the different planes for injection, one needs to know the detailed anatomy. The obvious danger here is the frontal branch of the superficial temporal artery, and this sits within the superficial fascial plane. And this is the layer immediately under the skin. There are, of course, anatomical variations, but one has to assume that the course of the artery is within the area of injection. The three different planes have their advantages and disadvantages. Let's revisit the anatomy briefly. The layers here are the skin, the fat, the deep fascia, temporalis muscle, and the bone. The superficial fascia lies just beneath the skin, and this is where the artery is. The first injection plane for filler deposition is in the superficial fat, and this is below the superficial fascia, and therefore it is below the artery. To deposit in this plane, a cannula is usually used, and it passes easily within the fat. A needle is usually not used because of superficial temporal veins. A needle can cause puncture to the veins, causing massive bruise. And if the needle inadvertently goes more superficial, it can also injure the artery in its path. A cannula can of course hit the artery, but the risk is a lot lower. The downside to injecting in this plane is that the result can be very lumpy because of the superficial plane. So in patients with very thin skin in this area, the aesthetic results is not as good. And also is probably not suitable for those patients with visible superficial temporal veins. This can make the superficial veins more pronounced and takes longer time to settle. One should not use high G prime or viscous filler because it is difficult to massage it into place. As a result, can be very lumpy. With the cannula technique, this is the simplest injection technique out of all the three planes. And in general, less fillers are needed to show results also. The second layer. Injection of filler is into the subdeep fascial plane. As the deep subfascia is quite thick, penetration is only possible with a needle. The cannula won't be able to penetrate the deep fascia. This is my favorite layer as it gives a smooth and gentle lift. It requires less filler compared to the supraperiosteal plane, which is much deeper.
but it will require more filler than the superficial fat plane. Aesthetically, this gives the best result. The challenge is for the injector to identify the needle has penetrated this deep subfascia, and this is when the needle suddenly gives way or the injector will feel of less resistance. This is illustrated in the Anatomy for Injectors module. This deep fascia is quite thick, but it is not tightly adhered to the temporalis muscle, and therefore it is quite easy to spread the filler underneath it. I usually inject a bolus of 0.1 ml and then change the direction of the needle, moving to a different part of the deep subfascia. If the area to be filled is a big area, then I will change the position of the needle to a different point. The pro is I won't use as much as filler as the supraperiosteal plane, and I get a smooth and even result, and less risk of making the veins more prominent. Adequate lighting is essential, and it is not difficult to avoid those superficial temporal veins. In the event that one accidentally punctures one of these temporal veins, withdraw the needle immediately and put pressure on the injection site. This should prevent bruising. But what about the risk of injury to the artery and veins, as we have to assume that these vessels are in its path? When the patient is resting, the caliber of the artery is small, and in limited studies of young female patients at rest, the artery is of the caliber of 0.5 mm. There are of course individual variations in the course and also the diameter of these arteries. If one injects with a needle into this plane, there is definitely a chance of hitting the artery. The third plane is the supraperiosteal plane. This is the deepest of all planes for filler deposition. The lift is subtle. Out of the three planes, this one will require most fillers to produce the same result. It is not difficult to identify this plane because the needle touches the bone. A needle has to be used because it has to go through the thick deep fascia and also the temporalis muscle. The risk of hitting the artery is the same as the injection into the sub-deep fascia. The entry point is identified as 1 cm behind the temporal fusion line and 1 cm posterior to the bony orbital rim. Technically speaking, the filler is in the temporalis muscle, which is firmly attached to the bone. Once the filler is placed, then it is massaged into place. The filler can only move along the muscle itself, as it cannot lift the muscle off the bone. This could be a challenge if a large amount of filler is required to fill this area. In patients with severe hollow, this may not be possible. What happens if the injection is less than 1 cm? Remember that the filler is trapped between the subfascia and the bone, even though it is in the temporalis muscle. The patient may feel a sensation of pressure or headache. In an actual case recorded, the patient complained of pressure after the needle is withdrawn. One could notice the pulsation of the artery. In this case, the artery has vasodilated because of the pain. Because of the vasodilation, the artery now has a higher chance of being injured. Absence of pulsation or negative aspiration should not give the injector confidence. What happens if the injection point is more than 1 centimeter away? The needle may need to be longer because the bone slopes away. And theoretically, there's more muscle mass. And therefore, there's an increased chance of injuring the muscle itself. It is advisable for a trainee to fully understand the anatomy and to be trained under supervision. An injector should evaluate the risk in each case and to vary the injection according to the situation. All the 3 planes have merits.